A very good afternoon, one and all. I hope you all enjoyed your lunch. It gives me a great pleasure to extend you all a very warm welcome to the CME and annual meeting of Obstetric and Gynecological Society of Northern India on behalf of Department of Obs and Gynae PGI Chandigarh. Thank you so much for accepting our invitation. It is an honor to have each one of you here. Now, I would like to invite Dr. Vanita Suri, Professor and Head Department of Obs and Gynae, to please come and give the welcome note.
Thank you, HP. Very good afternoon to all of you. Now, I welcome you all on behalf of OB-GYN Society to the CME and annual meeting of Obstetrics and Gynecology Society of Northern India. Now, last year we had conducted a drill on PPH one day before the CME, and it was highly appreciated by all. So continuing this series inspired by the last year's fact, we want to continue with it in cases of severe preeclampsia and eclampsia. Now this is another cause of maternal mortality after hemorrhage. Now this drill has been prepared by our very young, enthusiastic and energetic faculty, students and nurses from different departments: anesthesia, pediatrics, neurology, and of course obstetrics and gynecology. And they have done a lot of hard work. And I'm sure it is going to be a very good learning exercise for all you. And I promise you, you won't even have a wink of sleep in the postprandial siesta. And happy learning. Thank you.
So let's proceed with our session for the day, that is severe preeclampsia and eclampsia drill. For this, I feel privileged to invite Dr. Kala Vishisht, ex-professor, Department of Obs and Gynae, PGI Chandigarh, and an eminent private practitioner now, and Dr. Vanita Jain, Professor, Department of Obs and Gynae, PGI Chandigarh, to please come and share the session. Please, ma'am.
Good evening and welcome to the eclampsia drill. As Dr. Vanita Suri just pointed out, the drill that we did in the last meeting, the PPH drill, was really appreciated, and that gave us the encouragement to do a drill on another obstetrical emergency, which is an important cause of not only mortality but leads to a lot of near-miss complications. And this is a complication which requires a quick response team from the attending obstetricians. So we have prepared the drill with the Department of Gynae, anesthesiology, neonatology, neurology, and the nursing colleagues. And Dr. Meenakshi, I would hand over to Dr. Meenakshi to continue the.
Thank you, ma'am. Thank you very much, and good afternoon to all of you. So, very briefly said by Dr. Vanita that preeclampsia and eclampsia is one of the very important obstetric condition, and it is a condition that needs to be understood by all physicians, be an obstetrician or physician, anesthetist, neonatologist or a neurologist, and including sisters also. So, basically, many times we call them to help us and to assist us in a complicated cases of eclampsia or preeclampsia. So, to demonstrate the role of all these specialists, we have planning to have a drill. Aim of this drill is to demonstrate the role of all specialists in a chronological way, starting from severe preeclampsia up to a full manifested eclampsia, and even in a patient who did not get up and is not well even 24 hours postpartum. So, for demonstrating this drill, we have planned for 4 clinical scenarios. So, in that scenarios, we will try to present how do we deal with these patients in our labor room by having a multidisciplinary approach. So, for this, to begin with, I'll be dealing with this a very concept of this disease and some diagnostic criteria and its ever-changing diagnostic and guidelines regarding the management also. So, to begin with, this is as I said, it is a multidisciplinary approach. As Madam rightly said, it is a team that is working on this. So beginning with, it is As we know, preeclampsia is a hypertensive disease that is specific to pregnancy only, and it may be seen in 4% of all pregnancy. If we say the most common disease, it is after anemia, is the second most common medical disorder in pregnancy, and it is known to be one of the major cause of maternal, fetal, and neonatal morbidity and mortality worldwide. So if we see with hemorrhage and sepsis, that makes a actually deadly triad of maternal mortality. According to WHO 2012, it's a major life-threatening condition causing severe acute maternal morbidity. So in last 4 to 5 years, there have been many changes in regarding the diagnostic criteria and the guidelines regarding the management also. So our drill will be including all management, including all these guidelines and diagnostic criteria mainly. The classification is as same as it was since many years. That includes gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and chronic hypertension with superimposed preeclampsia. Coming to the diagnosis of gestational hypertension, it is just to begin with the drill. It is a hypertension more than 140/90 or equal to more than 140/90 in any woman who is previously normotensive after 20 weeks of period of gestation and on at least 2 occasions. If it is mild, it is usually have mild favorable outcome, and if it is severe, outcome is usually equivalent to severe preeclampsia. Coming to preeclampsia, that is our main DIL is concerned with. It is the same BP of 140/90 at least on 2 occasions plus, or it is a BP, one reading of 160/110 BP records, plus it is a proteinuria that may be in form of more than 300 milligram per 24-hour urine collection, or protein creatinine ratio equal to 0.3 milligram per cent, or it may be a random albumin, that is 1 plus urine albumin. So what do we do if there is no proteinuria? So that is basically, it's the biggest change in the diagnostic criteria of the preeclampsia. Even if there is no proteinuria, any patient who is presenting with new onset hypertension and any of the following severe feature, she will be categorized into preeclampsia with severe feature. And these are thrombocytopenia, where the platelet count will be less than 1 lakh, and renal insufficiency, where the serum creatinine will be more than 1.1 milligram per cent, or it may be a doubling of creatinine. They may be liver function may be impaired. Patient may present with pulmonary edema or severe cerebral or visual symptoms like headache and blurring of vision. So, in fact, ACOG task force say that there is no term like mild preeclampsia, and it should be not be used because it gives us a false sense of security. Mild can never be categorized. It can anytime convert into a severe preeclampsia. So, as of now, it is preeclampsia that may be with or without severe feature, and these are the severe features that I already enumerated. So it's a further modification in the concept of this disease, that findings like significant proteinuria that were used to affect our management of the patient, it is no more and no longer part of the diagnostic criteria for severity of the preeclampsia. There's no difference in the maternal outcome has been seen in. So it is actually a all or none phenomena. Proteinuria is there, or it does not matter how much it is this. And in fact, it has been seen that in eclampsia and in the patient with HELP also, it is seen in the 10 to 20% patients only. So the next 4 slide, I will be dealing with the 4 conditions where according to the latest guidelines, there is no doubt about the timing of delivery. So any condition where the mother or fetus is unstable, like eclampsia, pulmonary edema, DIC, uncontrolled severe hypertension, non-viable fetus, or abnormal fetal test result, or when patient is presenting with abruption and IUFD, these are the conditions when we have to terminate the pregnancy irrespective of gestational age. Regarding the delivery at 37 weeks, there is no confusion that any mild gestational hypertension or preeclampsia without severe feature pregnancy should be terminated at 37 weeks period of gestation, and it is a good level of evidence. There are certain conditions where the mother and fetus is relatively stable. We can defer the termination of pregnancy, maybe for 24 to 40 hours. It's for the fetal lung maturity and for the effect of corticosteroids, and these are HELEP, IUGR, severe oligohydramnios, reverse and diastolic flow, or any new onset or increasing renal dysfunction. Delivery at 34 is recommended for any preeclampsia with severe feature, and expectant management beyond 34-week gestation is not recommended. So we'll be presenting now 4 clinical challenging scenario. Apart from these conditions where the timing of delivery and the is very clear, there are certain difficult scenarios also. So we'll be presenting with these scenario. So in these, in 4 scenarios, these first 2 patients are, they are less than 34 weeks period of gestation, and one of the patient will be presenting with the HELP syndrome. And in last 2 scenarios, it will be a term, these 2 will be the term patient and will be presenting with eclampsia and shortness of breath. So